consultant here at King's. The talk that Samson asked me to give, he sort of had a few different topics that he wanted covered. This is one that I had a talk already prepared for, so I thought I'd share this. This is a talk I gave at the BSc conference last year. The target audience there was physiologists more than doctors, a bit of both, but mostly physiologists. But I think a lot of what we're going to cover is going to be relevant to both groups. It may be that they know a little bit more echo and maybe a little bit less sort of cardiac physiology, or certainly the physiology of the critically ill. But I think it's useful to revise the physiology in critical illness as well, because that is going to underpin all of the echo assessments that we're going to make. First thing I'm going to say, I forgot to, sorry, I've moved rooms, so I haven't got the slide that I put up next. So the first slide was going to be a shameless plug for the Foundations of Echocardiography YouTube channel. So I have got a video lecture that covers basic 2D volume assessment that's on YouTube. If you haven't seen it, I would obviously recommend that you go and look at it. It's about an hour long, and it mostly provides the evidence it provides a lot more evidence to some of the statements I'm going to make as we go along. So as we go along, I'm going to say, I believe X, and I'm going to provide some evidence. There's a lot more evidence to support that. So if that sounds like the sort of thing that you're interested in, then that's there. And if that sounds tedious and you'd much rather have a summary, then this is hopefully going to be a slightly shorter version. Okay, so going to the question, what do you think about the volume, the fluid status? What do you think of the volume? What's the volume assessment? Really common question, asked all the time, and perhaps not always asked by people who fully understand the question that they are asking. What do you think of the fluid status? Can mean a lot of different things. I think what people mean when they ask is, this patient is shocked. If I give them fluid, am I going to reverse partially or completely their shock state? If that's not their question, if they're asking a different question, then I'm afraid I've misinterpreted it, and I'm going to be giving them the wrong answer. So the first question, I think, is, I've got somebody who's shocked. Can I get them out of shock by giving them fluid? And is the benefit, do I get them out of shock enough to negate all of the negative side effects of giving excess fluid to somebody? And like many things in medicine, there's a balance between the positives of improving the tissue perfusion against the negatives of having excess fluid, and we'll look at that in a second. Again, like I said, this was a talk originally designed for a slightly different audience, and so we went through, first of all, just making sure everybody in the room knew what we meant by shock. So I don't need to give you guys a definition of shock, because you could give me one, and I'm sure it will look extremely like the one that's up on screen at the moment. The different types of stroke, I think, again, this is something that we know because it's what we see and do all day, every day. But I also think it is worth, I'm going to label one point here now. I think the number one thing that echo can do to help you determine whether or not you should or should not give fluid to a shocked patient is to narrow down your differentials and give you a better understanding of the etiology of the shock. So many of these different shock etiologies here, as you can see, you can either see very, very good diagnostic evidence on echo, or you can see sort of circumstantial evidence that's going to help you, lead you to that diagnosis. And beyond all of the other things that we're going to touch on in the next sort of 40 minutes or so, I think the single most important thing is helping you either confirm that you do know why your patient is shocked, or help you understand why your patient is shocked if you don't know. And I think that is more useful than any of the other things that I'm going to tell you about in a second. Okay, then we need to have a framework whereby we understand why giving fluid might conceivably help somebody who is shocked. If we're going to have that framework, then we're going to understand when it's going to be helpful and when it's not going to be helpful. This is revision for you guys, I'm sure. First thing to say, the amount of blood that goes into the heart is equal to the amount of blood that comes out of the heart, unless you've got a shunt lesion. So venous return and cardiac output should be the same. What is it then that determines venous return? What determines how much blood goes into the heart? And you can think of it as the gradient between the pressures in the vessels supplying the heart and the chambers within the heart that receive blood. And when we think of this model, we typically think about the mean systemic filling pressure, so the mean pressure from the aortic valve to the inlet of the right atrium. So the pressure everywhere from the aorta to the arterioles, to the capillaries, to the venules, to the veins, and the right atrium. But actually, you've got two simultaneous gradients to consider. You've got also the mean pulmonary artery pressure and the left atrial pressure, and also that could be a location of hold-up. You can have a problem with that gradient, the left heart gradient, but we typically think of it in terms of the gradient between the body's arterial and venous system and the right atrium. And the greater this gradient, the more blood will return to the heart. And assuming that the heart can move that blood forward, then the cardiac output will increase. If the heart isn't able to move that blood forward, then what will happen is the cardiac output won't increase, but the right atrial pressure will go up, and that gradient will therefore decrease, and the venous return will decrease. And that's a conceptual model that we can use to help us describe all different types of shock, and then work out when we don't think this would be fluids would be helpful. One of the things that we do in health and in sickness is we modify the mean systemic filling pressure by contracting and relaxing the circulation, but particularly the venous portion of the circulation, in order to generate a greater gradient or not, depending on what we need at that moment. So we can change our mean systemic filling pressure in health depending on our demand. The cardiac output, as we said here, this is just labouring this point. It's the difference or the gradient between the right atrial pressure and the mean systemic filling pressure. So if we imagine that these two axes have the same values running up each side, if the right atrial pressure is 0 and the mean systemic filling pressure is 0, there will be no flow. If the right atrial pressure is 10, but the mean systemic filling pressure is also 10, there will be no flow. You obviously can't have a situation where the NSFP is lower than the right atrial pressure, because that would cause retrograde flow. And you can see that as you move towards a greater NSFP or a smaller RIP, that's going to increase cardiac output. So I think that's probably revision. It is how all of these talks do start. It's how we sort of set ourselves up to go forward. Then we do this diagram next. This is the next diagram. You'll have seen these if you've seen these sorts of lectures before. So this is a graph comparing right atrial pressure and venous return, aka cardiac output, for different mean systemic filling pressures. So if we look at this middle line here, this middle line, this blue line in the center, transects the x-axis at a value of 10. So when the right atrial pressure is 10, there is no flow. Therefore, this must be the line of a mean systemic filling pressure of 10. And you can see if your MSFP is 10 and your right atrial pressure is 6, that's your cardiac output. If your mean systemic pressure is 10 and your right atrial pressure is 3, then that's your cardiac output. And you can see that for any given mean systemic filling pressure, your cardiac output increases as your right atrial pressure goes down. And you can see that it sort of levels off as you get to very low right atrial pressures. Now, once we've got that graph, then we can lay some lines over it. So each of these lines represents the change in cardiac output that would be expected as you moved between different mean systemic filling pressures for hearts that are performing differently. And we typically talk about it being ventricular contraction, but it's really the whole heart, how the whole heart is going to respond when you increase the mean systemic filling pressure. Remember, the reason we're going to give fluids is we're going to give fluids to push the mean systemic filling pressure up. That's why we're going to do it. So let's take this yellow line. This yellow line in here. Let's imagine that this is our patient in health at rest. Let's imagine that they've got a mean systemic filling pressure of 10, so they're on this middle line, and they've got a right atrial pressure of 4, which is going to be about here, isn't it? And you can see that this is going to be their cardiac output. Now, if we push them up they're on the mean systemic pressure line, so their right atrial pressure is going to be here. So this is what their cardiac output is going to be. Now, we're going to push up their mean systemic filling pressure, and we're going to move them between these blue lines. And as we move them between these blue lines, their cardiac output is going to increase. Eventually, we're going to reach a point at which the rising cardiac output plateaus and then stops. And we know this is our Frank-Starling relationship. Everyone's aware of this. And we can see that in this situation, we're not going to get to a plateau until we get to very, very high mean systemic and right atrial pressures. You can imagine then that this patient then starts to exercise, or maybe is given some sort of inotropy that's exogenous, and then they're going to move from being this yellow line to this green line, and now for the same pressures both in the vasculature and in the right atrium, they're going to have a different amount of cardiac output. We can push their cardiac output up by moving them from the yellow line to the green line, and likewise they can have either pathology or some other problem that's going to make their heart fail and move them from the yellow line to the orange line to the red line. You can see here that moving from an MSFP from 10 to 14 makes this patient's cardiac output go up by this much, whereas this patient's cardiac output is going to go up much less, a much smaller rise, the same change in MSFP based on the Frank-Starling relationship that this patient has. And then we can think about all of our different diseases as being how they impact MSFP, how they impact atrial pressure, and then why they might cause a low cardiac output. So hemorrhage, nice easy one. Right atrial pressure, or both atrial pressures, but right atrial pressure specifically, what we're talking about it here, is going to fall, but MSFP is going to fall to a greater degree. And so these two arrows minus this arrow means cardiac output goes down. And then you can think about diseases which go in the opposite direction. So ventricular failure, the MSFP will typically go up if you have, say, an isolated right ventricular infarct. You'd expect your MSFP to rise, but you'd expect your atrial pressure to rise to a greater degree, and therefore that will produce a decrease in cardiac output. Why might we not want to give fluid to everybody? Again, you know this, but just to labour points that you guys will know, there is an association between giving excessive fluids and poor outcomes, including more risk of dying, more risk of spending more time on the ventilator, more risk of spending more time in the ITU, more risk of acute kidney injury and ending up on a filter. And the reason for this is probably because, or one of the reasons is probably because you're going to be pushing up your MSFP the more you give fluids, and that's going to produce venous congestion and tissue edema within these organs that are trying to drain into the heart, potentially decreasing the perfusion across that organ, and all of these things combined are going to have negative consequences. So sometimes you want to do it, sometimes you don't. On the YouTube video, there's loads and loads of each of these papers. I go into sort of a little bit of information about what they show, but I won't do that here. You can look that up later if it's of interest to you. Okay, so super important. Sometimes you know whether or not to give fluids. If you have a patient who has been stabbed multiple times in the abdomen and in the great vessels, and they come in and they have got a low systemic blood pressure and they are tachycardic and their lactate is high and they're obtunded, you shouldn't be reaching for the echo probe to try to work out if they are volume responsive. There should be no finding you find on echo that is going to make you think that this patient shouldn't receive blood. So if you already know what to do, you don't need to go to the echo. The echo is potentially most useful when you don't know what to do, when you need additional information. Likewise, you've got a patient who had pneumonia. They have been on antibiotics for 2 weeks, or a week. They've been on ICU for 2 weeks. They've got congested chest on imaging, and they've got lots of tissue edema, but they're hemodynamically stable. They're in a weaning phase. You're trying to get them off of the ventilator. Don't put a probe on them, okay? Because someone's going to put a probe on them. They're going to see something that they think makes them look fluid responsive, and you spend 2 days getting 2 litres off, and somebody's going to put that 2 litres back in overnight when there was no problem trying to be fixed. So point number one, if the patient's not shocked, you don't need to do this. Point number two, if you already know what to do, then almost certainly the echo shouldn't be changing your mind. And if the echo does appear to be changing your mind, you have to stop and think, what is it? I already knew what to do. What on earth am I seeing that would change my mind? Okay, so having said all that, that's all that. We've not even touched on what we should be looking for in echo. Now we're going to get to the echo. Okay, so what on earth could you look for? So we're going to look through some measurements and variables that people have tested experimentally to try and see how they will help us predict what will happen when we give fluid to our patient. So this one I really like. This is a paper where they looked at patients undergoing general anaesthesia. These patients were going to go and have coronary artery bypass grafting. And this was done, I think, in the 90s, 94. And if you read the paper, it looks very much like they were venesecting patients prior to going on to bypass, and then taking that fluid and putting it in citrated bags, storing it, and then reinfusing it at the end of the procedure. And that, I think that's what they were doing, as far as I can tell, and that may well have been normal practice for cardiac surgery. Then I'm afraid I should have, and forgot to ask somebody who was practicing in the late 80s, early 90s, to find out if that's what they normally did. But that is what they did in this paper. Okay, so let's look at these dotted lines. These are their control group patients. So these patients had anaesthetic, but did not have venesection. So you can see, so this is what is the effect of the anaesthetic, therefore we can remove that. So EDA, end diastolic area on TOE. So the suggestion from the authors here is that as you take fluid out of the circulation, the heart will get smaller. And so if you've got your control, if you anaesthetize them and then don't take fluid out of the circulation, their hearts do not get smaller. Their end diastolic area holds relatively stable. Their end systolic area holds relatively stable as well, slightly decreased, but not massively decreased. So the size of the heart doesn't change dramatically if you just give somebody an anaesthetic. And in addition, their central venous pressure remains relatively static, and their stroke volume remains relatively static. Now, these white circles and these black circles, these are the patients that receive venesection. The white circles are patients undergoing coronary bypass grafting, but who had an ejection fraction that was within the normal range before they started. And you can see that in these patients, their hearts got smaller as they had more and more blood removed. So 15% of this is percentage of circulating volume that's been removed. So they were taking out probably about 750 mils from these patients before going on to bypass. As you can see, the EDA gets smaller. It starts around about 16 centimeters squared, ends up around about, what's that? Probably about 30. So probably somewhere, sorry, no, the scale's slightly different. So they've gone from about 18 to 13. Okay. Their end systolic area also gets smaller, but to a lower degree. Because their end systolic area is getting, the drop is not as much and not as great as in the EDA group. That means their stroke volumes go down, and also their central venous pressure goes down. And if you've got patients who have got 4 left ventricles, so patients who are in left ventricular failure before they go under anaesthetic, they have exactly the same changes in exactly the same direction. So they also get smaller end diastolic areas, also get smaller end systolic areas, also their CVP goes down, also their stroke volume drops. So that sounds fantastic. We know that when we take blood out of circulation, the heart gets smaller, physically smaller, and we can look at the heart. So that sounds like it should be useful. But part of the problem here, if you look at these patients who've got failed hearts, at the end of 750 mils venesection, their end diastolic area is still about 18 centimeters squared. And that is slightly higher than the patients who have got normal ventricles before you even start. So the problem here is that you need to know whether the heart is normal, whether it's and what size it was before you began venesecting. So there's such a wide range of normal values within a healthy population. There's a much greater range of pre-acute illness values within a diseased population. So if you know what size the patient's heart should be, then you can sort of maybe use this. That really is only going to apply if you had already echoed them during this acute phase. Otherwise, that's probably not going to work. These are 4 other papers, all looking at the same relationship, but looking at it reverse. So all 4 of these papers look at what happens if you take somebody and give them fluid. Does their size of their cavity get bigger? And broadly, the answer is yes. So let's look at these patients. These are all fluid responders. This is their value of their end diastolic area. So this is the cross-sectional area in a TOE. And you can see that for all patients, apart from maybe this one, all of them, when they were given fluid, their end diastolic area increased. And you can see that as a group, it increased, and as an individual level, it increased. If you look at the non-responders, they also had a slight increase, but it was much more subtle. So you get less of a response in the non-responders. But if you're trying to identify a single threshold at which you can say, okay, fine, end diastolic area is greater than or less than X, is that going to help me identify whether this patient is going to respond or not to fluid? The answer is clearly no. The overlap between these two populations, people who do respond well, people who don't respond well, is so great that there's no value in here that you can use as a single value that's going to give you a useful discriminator. So then you can say, well, can I use a split value? Can I have two cutoffs whereby I say, okay, my value is greater than X. I think that I can say one statement confidently about them, less than Y I can make another statement. Well, if you want to exclude all your non-responders, you want to find patients, you want to say, what I don't want to do is accidentally give fluid for non-responder. Well, you can say, well, if the end diastolic area is less than about 11, then they're probably not a non-responder. But then if you're looking at 11, then you're going to not give fluids to 3/4 of the patients who are responsive. Likewise, if you want to do it the other way around and say, okay, fine, what I don't want to do is accidentally label somebody as a responder. So I'm going to say, if they are above 24, then they can't be a responder. Well, that's fine, but then you're going to miss 75% of your non-responders. So huge overlap, no single value is going to be useful. Like I say, if you saw their heart yesterday and you knew how big it was yesterday, and now something has changed and it's a different size, that might be useful. But I also think you need to wonder what pathology has brought about that change in size. Because yes, it could be fluid shifts, but if the heart has got bigger, it's more likely to be ventricular failure or some other cause of ventricular, so primary or secondary ventricular failure. But it is simply that you've just gained fluids, unless you know that that's what you've done and you've resuscitated them. Okay, so let's look at some actual movie pictures. This is a patient who was a young guy. Here we go. It says at the top, 27-year-old polytrauma patient. This would have been a motorbike collision, almost certainly. This guy had come off his bike and hit a car at high speed. He had basically all 4 limbs were broken. He had lacerations within the abdomen. He had extensive thoracic trauma. He will have had a flail chest on both sides with bilateral chest drains. And he had been in hospital in ITU for, I think, about 48 hours. And some of these patients we see, particularly young patients, they mount this massive inflammatory response, and he put his temperature up to greater than 42 degrees. And now, in the context of being having a temperature of greater than 42 degrees, he ends up on about 0.8 of noradrenaline. His blood pressure, I want to say, is something around about 65 systolic. And my colleague who was looking after him started to pour fluids in, but called me to say, can I come have a look and see what was going on? He's got extensive chest trauma, so there's no question of getting thoracic windows, and so we've got a TOE here. So this is a transgastric short axis, and you can see that it is not playing, but if it were playing, let's get back there again. So the transgastric short axis, you can fit at the mid-papillary level. This is akin to your parasternal short axis. That's your right ventricle there, that's your left ventricle there. And it's going at a very, very great speed. And so whenever you've got a great speed, it's easy to overestimate just how much contraction you've got. But actually, there's a huge amount of contraction. This is hyperdynamic. This isn't misleading. This is actually hyperdynamic. And his end diastolic area was almost nothing. It was coming down to a few centimeters squared. So very, very low levels. I don't think big. You can see it there. And on the right, this is a mid-esophageal 3-chamber or long axis view, and this is akin to your apical 3-chamber, but just turned upside down. So I'm sure everyone recognises, but here you've got LA, aortic valve, and this is the left ventricle with the RVOT just here. You can't go back to play. Okay, so this patient had and absolutely sort of coming down to nothing, left ventricle, kissing ventricles we talk about sometimes, sorry, kissing papillary muscles we talk about sometimes. Yes, he's got that. So yes, he needed fluid, but if we hadn't had the echo, we were already giving fluid, and we were already going to give him fluid. So what do I think was the utility of echo in this case? I think it was more important to make sure he didn't have cardiac contusions, make sure that his ventricular function was normal, make sure he didn't have a tamponade that had developed somehow. So I think excluding those other pathologies was useful. I think it gave us confidence, but we just needed to give him fluid. And I think over the next couple of hours, he got given about 4 litres of fluid, and it massively improved his sort of hemodynamic situation. Be careful. Kissing ventricles absolutely does not always mean that the patient is hypovolemic. Far from it. So this is a patient with right ventricular failure. You can all pick that up. So she's got a, we use the term submassive PE, but we would probably move away from that. She's got an intermediate high risk PE, and she's got dilated right ventricle with displacement of intraventricular septum from right to left. This patient here is a gentleman with severe chronic hypertension, untreated hypertension, who's got severe left ventricular hypertrophy, and his cavity is small because the muscle wall is so thick. So both of those things would potentially present with a small end diastolic and end systolic area, and for both of those patients, giving them fluid may be the wrong thing. Certainly for this gentleman who's got very high left atrial pressure and is in pulmonary edema requiring intubation, giving him fluids would be the wrong thing to do. Okay, so size of the heart, usually not helpful, only helpful in the most extreme situations, which are the situations when you shouldn't be doing an echo anyway. What else do people look at? People look at the size of the IVC. People do this. So what we know is that in spontaneously ventilating patients, there is a relationship between the size of the IVC in terms of its diameter in the subcostal long axis position and the right atrial pressure. That is true. It's been shown in many studies. You do see a relationship. Let's look down here at this graph here. So here we've got patients who've got a right atrial pressure of less than 8, and here we've got patients with a right atrial pressure of 8 or more spontaneously ventilating. Let's look at their IVC diameters. This group has got smaller values than this group, so that is useful. You can use a threshold, and the BSc guidelines for describing right atrial pressure in an outpatient setting, they say 21 goes into their algorithm for predicting right atrial pressure, and you can see that it's relatively discriminatory. So most, but not all, patients with a normal right atrial pressure will have an IVC less than 21. Many, but far from the vast majority of patients with an elevated right atrial pressure will have an IVC that's more than 21. So if you use 21 as your threshold, you'll probably not mislabel too many people with normal right atrial pressure based on this data, but you'll miss an awful lot of people with high right atrial pressure. Again, a lot of overlap between these two groups. It doesn't work so well when you start to apply PEEP, and the more PEEP you apply, the less well this relationship, this correlation between IVC size and RAP is. We also know that RAP does not correlate well with fluid responsiveness. We know this from our centralized studies that we've had, of which there have been very many. So we're trying to see if we can use IVC size to predict right atrial pressure, which we've already demonstrated beyond the point of never needing to ask that question again. We've shown how it is not helpful at the bedside. Not as a snapshot, not as a single measurement that's going to tell you what to do out of context. It is potentially helpful in that situation where you're monitoring somebody over time, of course. And this is another data set, but it shows you very similar information to this data set. Okay, this is a group that produce a huge amount of this sort of data. This is the French group from Paris with William Baron heading them off. They've done many ICU echo studies come out of this group, and here they're looking at ventilated patients now. So they're looking at IVC size in ventilated patients. and they are trying to see how useful that is at predicting fluid responsiveness. Here they're using passive leg raise to try and tell people fluid responsive. They looked at a really big data set for an ICU echo study. I think they had many hundreds, maybe close to 500-ish sort of patients enrolled in this. First thing to say that in almost 1/4 of all the patients, they were unable to identify or measure reliably the IVC, and all of the people who were performing these scans were people who had performed a minimum of 2,000 studies before. So these were sort of experts within the field of critical care echo, and they couldn't see or measure IVC about 23% of the time. When they could measure the IVC, there was a statistically significant difference in IVC caliber between those people who did and did not respond to fluid. So the green line here is the median IVC of the patients who did respond, and the blue line, the median IVC diameter of patients who did not respond. And you can see that those two lines are separated. And because they have so many hundreds of data points, then they are able to achieve a statistically significant separation. So that's great. But if you look at these two sort of graphs, they overlap massively. And so it's very, very difficult to find a value or even a set of values that allows you to predict with any degree of certainty how somebody will behave if they're given fluid. These dots here are the individual patients within their data set, the ones in whom they could manage the IVC size, measure the IVC size. So if you say, okay, fine, the middle group, that's our grey zone. So let's throw away our grey zone. Okay, well, the first thing you notice is that you're throwing away more than 80% of your patients. So if you decide that you can't do this in more than 80% of your patients, but you only want to do it in 20% who are at the extremes, if you use an IVC size of 13 or less to predict fluid responsiveness, or to label somebody as fluid responsive, well, that will be correct about 2/3 of the time, but it'll be wrong about 1/3 of the time. And likewise, if you use a value of 28 as your threshold for deciding that somebody is not going to be responsive to fluid, then again, you're only going to be correct around about 2/3 of the time, and you'll be wrong about 1/3 of the time. So even by excluding 80% of your patients and only using the outlying 20%, you still can't achieve a positive predictive value that reaches 70%. This is more data. I don't need to go into it. You can see there is a difference between these two dots. This dot is higher than this dot, but the overlap of these two populations is so vast that it doesn't have any clinical benefit. Okay, so what about, so IVC size, probably not useful. What about change in IVC size over the respiratory cycle? Again, you guys know this, I'm just going to say it out loud quickly just to make sure that everyone's caught up. So the normal thing that happens as you take a breath in is that your intrathoracic pressure falls. The fall in intrathoracic pressure is transmitted partially through the right atrial wall into the right atrium, so the right atrial pressure falls. But the extrathoracic vessels, of which most of your vessels are extrathoracic and they're feeding into the right atrium, they don't have any transmitted change in pressure, therefore they don't change. So therefore your MSP stays the same, your right atrial pressure falls, you get a drop, you get an increase rather in that gradient. And so what happens as you breathe in is you suck blood out of your inferior vena cava into your right atrium, and on inspiration, your IVC collapses, and you can see that here. And then on expiration, the exact opposite thing happens. So the IVC will be maximally dilated at end expiration, and then will collapse on inspiration. You can measure the cavity, the vessel diameter at both maximum and minimum diameters. You can take the percentage, not percentage, you can take the absolute difference, you can divide it by the maximum diameter, and that will give you either your collapsibility, if it's collapsing on inspiration, or if you've got somebody who's on positive pressure ventilation and is receiving additional volume, receiving an increase in intrathoracic pressure, therefore an increase in right atrial pressure, then you're going to get distension, because that relationship will be reversed. The problem that I have with this is that people are trying to work out the central venous pressure. They are looking at the magnitude of IVC caliber change, and they are trying to equate this magnitude of change with this central venous pressure. And they're sometimes, or often, or always not considering what is the change in intrathoracic pressure and the change in intrathoracic volume. So if you're going to look at this relationship, you need to know, how is your patient being ventilated? Is this a pure mode of positive pressure ventilation, or is this a hybrid mode, like a pressure support, where the patient's got some effort, some inspiratory effort, and then that inspiratory effort is topped up by additional pressure? Or is the patient breathing on their own? And if they're breathing on their own, is this the quiet, gentle breathing we see in an outpatient setting? Or is the patient got type 1 diabetes, they've got a diabetic ketoacidosis, and they're breathing very, very quickly to offset that acidemia, and therefore they are going to have a very big change in intrathoracic pressure. So when I report my echoes, if I am talking about any kind of respirophasic variation, the way I set out my echo report is going to have the patient's background, a little bit about the current situation, the presentation, a bit about the hemodynamics. I'm going to write down, this is their heart rate, this is their blood pressure, this is what drugs they're on. I'm going to write about how they're being ventilated, but if they are spontaneously ventilated, I will sometimes talk about their respiratory rate, but also their work of breathing. And if you've got a CO2, if you've got somebody who's got a PCO2 of 1.8, because they've got profound metabolic acidosis and they're working extremely hard, put that in your hemodynamic section of your report, because it really shows this is somebody we're expecting to have huge, colossal changes in intrathoracic pressure. And obviously some respiratory disease will also produce similar kind of effects. Okay, so what about this then? What about using collapsibility and distensibility of the IVC to try and predict fluid responsiveness? This has been studied a lot. There are many papers that look at this. There are also many meta-analyses that look at this, and this is just one of those. This is one, here you can see I've highlighted those papers where the patient's spontaneously ventilating in green, those papers where the patient's breathing via some sort of mechanical ventilation through in this sort of blue boxes, and then these sort of grayed out ones that are where it's not obvious from the paper how the patient is breathing, basically. What you'll notice is that all of these papers are performed in different physical areas. They are using patients who have got different diseases. They are ventilating the patients or breathing the patients, and when the patients are ventilated, they're ventilated in slightly different ways, although most patients will be ventilated with a tidal volume of at least 8 mils per kilo to 10 mils per kilo. They give different fluids, they give different volumes of fluids, they use different ways of assessing the change in cardiac output or stroke volume in response to that fluid. So there's huge heterogeneity amongst these different studies, which obviously makes it very difficult to pick out what's going on. And if you take all of these studies together, as these authors have, and you try to work out the correlation between vessel dimension change, then you get an error under the curve of 0.71. And that shows a modest but not perfect correlation. So if you've got an error under the curve of 0.5, that means that there's absolutely no relationship. You can flip a coin and you'll be as likely to get it right as wrong as you would by using any of these techniques. 0.71 means this is definitely better than flipping a coin, but it's far from anything that you should be hanging your hat on. If you are going to use this method, then it is suggested then some recommended cutoffs have been proposed. Different authors and different textbooks provide slightly different cutoffs. The most commonly quoted collapsibility index I can find is somewhere in the order of more than 50%. Distensibility index, much greater ranges of distension are quoted in literature, but you're looking at distension more than 15%, suggesting somebody is being volume responsive. Like I say, it's not a perfect relationship. A lot of things going into this equation which aren't measured. Okay, if you're going to look at the IVC and IVC collapsibility particularly, or distension rather, then there are many caveats, many situations where this doesn't work, and you have to know what these are if you're going to be able to not misuse this. So how is your patient being ventilated? As the peak goes up, the relationship between IVC size and right atrial pressure breaks down. If the patient has got low tidal volumes, then your change in your variability may be you may miss genuine variability because you're not creating enough of a change in the chest. What I would also say here is that low tidal volumes in these papers refers to tidal volumes of less than 8 mils per kilo of idle body weight. Typically in modern ICU practice, we tend to try to continue to ventilate patients at levels of 8 mils or lower, but even if they don't have ARDS, obviously they've got ORDS much less, and so therefore this shouldn't really be low tidal volume ventilation. This should be normal tidal volume ventilation, or simply not excessive tidal volume ventilation. That would be a situation where this wouldn't be helpful. Is the patient making any respiratory effort? Because if they are, they're going to have some unmeasured negative intrathoracic pressure, which is confounding the positive pressure you're giving them. Are they breathing continuously, or have they got any kind of sort of respiratory variation? When patients are spontaneously breathing, the normal way that we all breathe, and we're probably all breathing now, is not a uniform set rate. We have variation in our breathing, and the intervals between breaths is not uniform in health in us. If you've got diseased lungs, then you might find situations where not all of the thoracic pressure change is transmitted to the right atrium, and therefore you might get a false negative there. If your right ventricle has failed, then maybe the increase in afterload that the right ventricle is exposed to during positive pressure ventilation causes the right ventricle can't send blood forward against that increased afterload. And so the problem you've got now is you've got right ventricular failure that is cyclically causing a reduction in forward flow. And so you can get stroke volume variation because your right ventricle is failed. So acute cor pulmonale can do that, RV dysfunction can do that. Cardiac tamponade, again, that's going to obviously limit flow into the chest. Classically, you get a lot of stroke volume variation in cardiac tamponade in patients who are spontaneously ventilating, but in patients who are ventilated by machines, then actually that variation is diminished, and that's often not recognized by people. Particularly our cardiology colleagues may come along and assess the patient in whom tamponade is suspected and say, oh no, it can't be tamponade because the stroke volume variation is not great. But what they often don't appreciate is that in mechanical ventilation, that relationship is broken down, and so that shouldn't be used to reassure us. Increase intra-abdominal pressure, this breaks down the relationship between IVC size and RAP as well. There's other things there. I'm not going to go through absolutely all of them. Chest strains, if you've got chest strains in, or even to a great degree, you've got an open chest or a chest that's been opened, then when you've got negative intrathoracic pressure changes or positive intrathoracic pressure changes, some of those changes will be lost from the chest into the drains. And therefore the right atrial cyclical pressure change will be diminished because some of that pressure is going out of the patient's body. Okay, I don't know if any of that made any sense. If it isn't, we'll talk about it and go through it again in a second. Okay, so far we've not got anything that's been desperately useful. What about this suggestion? Dynamic tests to basically situations whereby we dynamically adjust the loading conditions of the heart and see what happens, see if the stroke volume goes up. This is attractive because it's effectively mimicking what it is we're actually going to do. So we're going to have a situation where we're going to increase the preload, and then we're going to see whether or not the stroke volume changes. And this is kind of the ultimate end of what we want to get to. Therefore, this should hopefully work a little bit, and it sort of can do in certain situations. Okay, so we talked already about respiratophasic variation. We talked about how the fact that when you take a breath in, you suck blood into your chest, into your heart, and on a ventilator, the opposite happens. So you give somebody a positive pressure breath, their intrathoracic pressure increases, the pressure in the heart increases, mean systemic blood pressure doesn't increase, the gradient falls, less blood returns. Okay, so what you can end up is a situation where the gradient is shifting back and forth. I don't really think this is the way it's always shown in books, but I don't really think that this is actually truly reflecting exactly what's happening. Probably need to make an animated graph that shows this a bit better actually. But you basically you're sort of mimicking what happens in a cyclical way, moving up and down this line. And as you move up and down this line, are you moving a lot up and down, or are you moving a little bit up and down? Okay, so you can see what happens as the patient breathes in or out. You can either measure the area under the curve, or you can measure the maximum velocity, and both are done in different papers. My preference is to measure the area under the curve when I think that the curves are big enough, because the area under the curve, as Chris told us at the last meeting, can be used to work out stroke volume. It's got a linear relationship. The area under the curve's got a linear relationship with stroke volume. So the area under the curve increases by 50%, stroke volume has increased by 50%. That's near enough absolutely true. The velocity of the blood has got not quite that perfect relationship, but it will move in the same direction typically, unless you're inducing obstruction to flow. As long as you haven't got flow obstruction, then as your stroke volume increases, your velocity should increase, and as it goes down, it should go down. Okay, so here we've got a lady. This is a 65-year-old lady with urosepsis. She is on the ITU. She is spontaneously ventilating. She has been in ITU for 10 hours, and in that 10 hours overnight, she has been given 6 litres of fluid, and she remains tachycardic and hypotensive. She's currently on a lot of vasoactive drugs. She is spontaneously ventilating, and she is acidemic, and she's tachypneic. So her PCO2 is 4 because she's trying to blow off some of that acid. And you can see that here we've got a pulsed wave Doppler. It's funny, you can't really see, it's not really a hollow envelope. It looks a bit more filled in. So it looks at first glance like it could be continuous wave, but you can see the sample volume there. And you can see PW, it's telling you it's pulsed wave Doppler. So this is pulsed wave Doppler, the sort of Doppler we'd use to measure the stroke volume. And you can see that this is an apical 5-chamber view. The sample volume is just below the aortic valve, or just, so it's just a bit anterior to the aortic valve, just below the aortic valve. You can sometimes see that, if you remember when Chris told us about the closing click of the aortic valve, it's visible there, it's visible there, it's not so visible there. So potentially, I maybe needed to move that sample volume 1 or 2 millimeters closer to the valve to get that closing click in, but I think it's probably good enough. Now, the sweep speed here, 100 millimeters per second, this means that these envelopes are very narrow. And because they're so narrow, I didn't really feel like I could measure the area under the curve and nail it and get it completely accurate. Also, she was very sick, so I think I was probably doing this in a hurry. So all I've done instead is I've just measured the maximum velocities of these 2 flows. You can see that she's spontaneously ventilating. So as she takes a breath in, she sucks blood into her right atrium. But on the left heart, which is the bit we're looking at the moment, she's going to hold blood back inside her pulmonary circulation. So the pressure drops in the left atrium, but it drops even more in the pulmonary vessels. So those pulmonary vessels stop feeding left atrium. Left atrial return drops, left ventricular filling drops, left ventricular output drops. So you can see we've got a drop in these triangles and a drop in the maximum velocity. And here we drop from 138 to 118 centimeters per second. So the way we do this is we do the absolute difference between the maximum and minimum. And if this was VTIs, you do exactly the same thing. Then you divide that by the mean of the 2 values, and you multiply by 100. So here we've got a patient who's got a stroke volume variation of 15.6, a spontaneously ventilating patient with stroke volume variation of 15.6. Okay. Can we do this in... It's interesting, I feel like I'm missing a slide. So in patients who are mechanically ventilated, this relationship sort of works. Oh, no, it's the next one. Okay, fine. So patients who are spontaneously ventilating, this is not a useful test. That is written in many, many papers and books. And there's not a lot of primary evidence that I've been able to find to explain just why it doesn't work. This is a paper that is relatively new and published in a well-known journal. So this is only 10 years old, in shock. And this is looking, and this got published, and this was patients who are spontaneously ventilating and looking at their aortic valve BTI percentage change. They've got 14 patients, and it got published in shock. So this isn't an area where we've got the 600 patients that Antoine Villard-Barral is recruiting to his studies. You can see that there was a greater aortic valve BTI variability in the variation, aortic valve BTI variation in the patients who were fluid responders and non-responders. But your confidence, these are standard deviations, I think, but maybe confidence intervals. They're very, very broad because they've got almost no patients recruited. And therefore they don't achieve significance. And when I was putting this together, this was the best paper I could find. So it's widely described as not being useful. It doesn't go on to tell you why it's not useful, but I think that the best explanation I've been able to come up from my own practice, my own experience, as well as what I've read, is that there's just too much variability in respiratory effort in your patient who is breathing by themselves. They take big breaths sometimes and small breaths other times, and you're never measuring that. And that variability breath by breath produces too much noise to help you in a clinically useful way. Okay, what about situations where you've got somebody who's mechanically ventilated? So let's take this Mark Weisel paper, these graphs are from that. So this is in a situation which is essentially as ideal as you can make it. These patients have had neuromuscular blocking drugs, so they are fully sedated, deeply sedated. They are on neuromuscular blocking agents, so they cannot be making any respiratory effort. So we know exactly, or as exactly as we can, the pressure changes inside the ventilator, and we sort of can infer from that pressure changes inside the chest to a degree. And you can see here that the change in the peak velocity across the aortic valve, they were able to get a reasonably good separation here. So these patients who are responders, all the patients who are responders had a stroke volume variation or aortic velocity variation of the situation that was greater than 12%. Whereas of the non-responders, only one did, and all of the others were at 12% or below. So in the patient who is got a neuromuscular blocking drug on board and is being ventilated at 8 mils to 10 mils per kilo of ideal body weight, then you can actually probably use this. So this is obviously a very, very small data set. There's other papers that produce a similar kind of pattern. We've got some animal data as well here. This graph is from this paper by Michel Slama, and what they did was they took a whole load of rabbits and they venesected the rabbits. So this is blood coming out of the rabbits. And you can see that they start with a stroke volume variation here around about 5%. And as they take bloods, they venesect their anaesthetized and mechanically ventilated rabbits. They can get the stroke volume variation up from 5% up to 35% as they take more and more blood out. And then they give all that blood back, and the stroke volume variation disappears. And likewise, at the same time, their actual measured stroke volumes decrease as they take blood out and are restored upon return of blood. Okay, so conceivably, stroke volume variation or stroke volume variability is a useful thing to look at in mechanically ventilated patients. There are always caveats. So anytime you're learning any rule, you must learn the caveats and when not to apply it. So let's look at situations where this relationship breaks down, you can't use this. Okay, if they're breathing, you can't use it. If they've got arrhythmias, you can't use it. Low compliance. So this is the ARDS patients. So you've got the ARDS patients, they are getting bigger shifts of pressure in the ventilator and in the airways, and because the lungs are stiff, not all of that pressure change is being transmitted to the right atrium. So they might have small right atrial and left atrial pressure changes for bigger lung pressure changes, and therefore that can give you a false negative. Open chest, if they've got chest drains, then you're going to lose pressure out of the body and you're going to diminish the pressure changes in those chambers. Increase intra-abdominal pressure, respiratory rate, is high for the heart rate. And there's a paper that found that this relationship breaks down when the respiratory, when the ratio of heart rate to respiratory rate is, okay, let's take some numbers. If your respiratory rate is 20, then your heart rate has to be at least 20 times 3.6 for this to work. How that works. Or maybe it's the other way, maybe it's the other way around. But either way, extremes of respiratory rate and heart rate, this fails. Right heart failure, we talked about this before. If you've got cor pulmonale, then actually what you might be seeing is you might be seeing the effects of increasing afterload on the right ventricle, therefore giving you a decrease in your stroke volume variation, an increase in your stroke volume variation, because you can't get that blood forward from the right ventricle. Okay, so then you say, okay, fine, so I can't use it in any of these situations, but I can still use it in all my other patients, right? That's so how many patients are you going to be left with? So there was a study in France. They did a single day in France, about 20 odd ICUs, and they surveyed at 1 minute in 20 ITUs how many of the patients in our ITUs can this be applied to. And there were 307 patients in the ITUs being sampled at that moment of time, and out of the 307 patients, 6 patients satisfied the preconditions for looking at this. So less than 2% of all patients in French ITUs on that day could have had this test and it be valid. So yes, in ideal situations, this is probably quite good, but unfortunately, those ideal situations are rarely present. And even then, what this doesn't tell you is, did the doctors already know what to do? Was this just simply discriminating between people who the doctors already knew that they could give fluid to if they wanted to, or didn't know? So this sometimes tells you, if you have no other information, what you might want to do. But of course, we're operating in a situation where we've got lots of other information. We've got history, we've got clinical examination, and many other things that are going to give us information. And what none of these papers do is say how much additional information does Echo give you, how much will it change your mind. That's what I think it would be really interesting to see, is how much can Echo change your mind for the better, and how much can it change your mind for the worst. Okay, so another test you can do, and this is probably we're finally getting somewhere. We're probably getting to the point at which we can actually do something useful now. So we can do a passive leg raise. We can't always do a passive leg raise. We can't do a passive leg raise in patients who've got spinal injuries or brain injuries, raised intracranial pressure on mechanical support devices. So there's a big plethora of patients who can't have a passive leg raise. But I would suggest that in my centre, which is a centre that has trauma, neurosurgery, cardiac surgery and cardiology patients with devices, still, for most of the patients on our ITUs right now, we could go and do this and it would be easy to achieve. Make sure you get your technique correct. Okay, so the patient should be on a bed that can be tilted without effort from the patient or the staff. You put them semi-recumbent, so their thorax is at 45 degrees. And their legs are completely flat, so take out any kind of knee break. And then this is a 2-person technique. This should not be done on your own. You are going to have your echocardiographer get an apical 3 or an apical 5 chamber window. They're going to place their probe in that position. They are going to set themselves up to measure the pulse wave Doppler across the valve, and then they are going to start recording the pulse wave Doppler across the valve. They're going to freeze, take an image, measure the VTI going out through the valve. If you want to do Vmax rather than VTI, there's evidence that says you can do that as well, and so that would also be an alternative. You're then going to get your second person to operate the bed and tilt the patient and keep the patient safe, but tilt the patient so their thorax is completely straight, but their legs down 45 degrees in the air. You obviously want to do as little as possible to the patient, but will interfere with your test. So you can't be changing your ventilator, you can't be changing your pressors, and obviously if a patient is awake and you cause him pain or distress, that might produce some kind of hemodynamic change within the patient that is that's going to confound the result that you get. Your echocardiographer, all they are doing is they are concentrating on, they're keeping their hands exactly in the same spot with exactly that perfect view the whole time, watching their view, making sure their sample volume doesn't move. Because if you move your sample volume just a couple of millimeters in either direction, you're going to get a false positive result. Okay, and then at that point, you're going to re-measure the VTI of the LVOT or the aortic valve velocity, whatever one of those variables you're measuring, and you're going to work out the response to that. So this is the response to an auto transfusion that you performed, and you're going to decide if you think this response was worth giving this patient the auto transfusion. So you've given them, let's say, 3 to 4 to 500 mils of effectively the equivalent change in MSFP of giving them 300, 350, 400 mils fluid. And then you're going to look at your change in your cardiac output. Now, if your cardiac output change that you see is less than 12%, then there's a very, very high and unacceptably high chance that this is simply intra-observer variation. So if you get the same person with the same probe and the same machine at the same moment in time to record the patient's stroke volume, then you're going to get variability that can be up to about 10 to 11%. So a value that is less than 10, 11% might be clinically useful, but you don't know that it's just not simply a measurement error. You really need to get up to about 12% to know it's not a measurement error, and that's why we typically use that as our cutoff. Other things to say: make sure you're measuring at exactly the same phase in the respiratory cycle at all times. We know that you get respiratophasic variation in stroke volumes, and therefore make sure that all of your Doppler measurements, I think it's true, all Doppler measurements, make them all at end expiration. Okay, so you know you're always making the right side of time. If you are the echocardiographer, you've got your hand on the patient's chest, you feel it go up, you feel it come down, you wait, it goes up again, bang, and you hit freeze, and you know that the last recorded envelope is the one that you want to measure. And you don't have to be looking at the patient's chest or feeling the patient's chest. You can look at the ventilator and flow waveforms. Some machines allow you to map breathing onto the ECG trace, and you've got a higher end machine. I tend not to find that terribly useful. In my hands, I don't get that to work very well, but you may have done that before, and that may work for you, in which case fine. Okay, so then you put your patient back. You don't leave your patient legs in the air. You put them straight back up. You put them at 45 degrees, and then you decide if you're going to give them fluid or not, because you've done your test and you've decided if you do or don't want to give them fluid, and then you're going to give them fluid. And if you give them fluid, then you must, at that point, do exactly the same thing you did with passive leg raise. You get your probe, you measure their stroke volume, you give them the fluid, and then you reassess their stroke volume and see if it worked. And something that I learned very early on is if you are doing something and it's working, keep doing it. If you're doing something and it's not working, stop doing it. So if you do it and it doesn't work, you have to have really quite good evidence about why you might potentially want to do it again. Okay, this is our patient who had urosepsis. This is our patient with urosepsis. We knew that stroke volume variability had to be taken with a huge pinch of salt. She's got very high work of breathing. She's asthenic. She's got low CO2. So a stroke volume variation of 15% may or may not be helpful. But either way, we decided we want to give her fluids. So we did exactly that. We gave her the fluid. And when you give the fluid, and when you do the passive leg raise, you have to wait till 60 to 90 seconds post-bolus or post-posture change before then making your measurements. And you can see here that these are both end expiratory, and I've written on and what I will often do if I'm making dynamic changes on the echo or during the echo, I'll type with the keyboard function what it is I'm doing so that I can remind myself later on when I'm writing report. So this was end expiratory pre-bolus. We've got a stroke volume here of 48 mils, and we get a 20% rise after the volume has been administered. Okay, let's put it all together. First question, is the patient shocked? If the patient is not shocked, then you can stop because you're not trying, there is no problem that you need to fix. If the patient is shocked, why are they shocked? It may be that echo helps you understand why your patient is shocked, particularly if you're looking after a multi-morbid population. They may have many different health problems. It may be that they've got sepsis, maybe they've got sepsis on the background of some structural heart disease, and therefore having that additional information is useful. So I would definitely be doing an echo here, but one of the main things I want to know is what's the etiology of a shock. I want to know that before I want to know what the IVC collapsibility is or what stroke volume variation is. Okay. Then the next question is, do you know whether or not you need to give fluids? If you already know, you can stop and ask any more questions, and you can do the thing that you already know. If it is very, very obvious that there's blood on the floor and not in the patient, then you can give them fluid and not worry about doing an echo. If you don't know what to do, then you do your tests. Okay, which tests might you do? You might do a passive leg raise if you can. Okay, if the patient meets the preconditions, then you can look at stroke volume variation. You can look at IVC and SVC collapsibility. Either way, if you can do a passive leg raise, that's perfect. And then at the very, very bottom, you're going to make a decision. You're going to make a decision to give fluid or not. And if you do give fluid, check to see whether or not it works. Okay, that is the end of that talk. I'm going to close that down and stop sharing and see if there was any questions there.